Welcome to the Veterinary Rehabilitation Podcast, where we aim to help fellow veterinary rehab therapists increase their knowledge and elevate their practice. I'm Megan Kelly.
And I'm Ane Lloyd. Together, we bring you the latest insights, research, and information in the field of veterinary rehabilitation.
This podcast is brought to you by Onlinepethealth, a leading continuing education membership for veterinary rehabilitation therapists. With Onlinepethealth, you'll have access to a wide range of online resources to help you stay up to date with the latest techniques, advances, and trends in the industry.
Our podcast features in-depth conversations with leading experts in veterinary rehabilitation. They share their own experiences and knowledge to help you improve your practice. Whether you're a seasoned pro or just starting out in the field, our goal is to provide you with the tools and the insights you need to succeed.
So join us as we explore the exciting world of veterinary rehabilitation and help you take your practice to the next level. Hey vet rehabbers, I cannot believe we are coming into the month of February. For those of you that don't know, February is our birthday month. 8 years ago, I had an idea that started off as a once-off webinar for veterinary rehabilitation therapists, and it was all about kinesiotaping in small animals. 8 years later, we have 3 different memberships: hydrotherapy, equine, and small animals. We have hosted 7 virtual conferences, the Vet Rehab Summit. And what started off with just me doing everything, being the web developer, the web host, the admin person, we now have a team of 12 people who work for Onlinepethealth all around the world to provide this amazing online learning experience for our vet rehabbers. So in the true birthday spirit, we would love to gift you, the vet rehabber community, 2 free webinars this month. For our non-members, you can go to onlinepethealth.com/gift to access them. And for our members, these will be added to your membership as a bonus. So the first webinar is on the Grayston technique. And this is all about an instrument-assisted soft tissue mobilization that utilizes a medical-grade stainless steel instrument. And this basically amplifies the feeling of palpation and expands the power of your hands as you work to identify any soft tissue irregularities in the horse's body, and helps to maximize the outcome of your manual therapy treatments. And this is sponsored by Grayston Technique and is focused on using this technique in horses. Our second webinar is sponsored by Canine Rehab Institute and lectured by their very own Cara Amstead. This is a great refresher, guys. It is all about radiology tips for veterinary rehabilitation therapists. So you can go to onlinepethealth.com/gift to sign up. This week, Ane and Narda Robinson from CuraCore Vet chat about anatomy. CuraCore is based on a strong knowledge of anatomy that can be translated into clinical application. They discuss the different courses offered by CuraCore Vet, as well as the anatomical connections of the stifle and the implications of this knowledge to stifle pathologies. So over to Ane and Narda.
Guys, and welcome. Hi, Narda. Thank you for joining us.
Hi, Ane. Good to be here.
Narda, will you please introduce yourself and let us know a little bit more about CuraCore?
Sure thing. My passion is medical acupuncture and working with my hands. I'm an osteopathic physician and a veterinarian, and have been for about 30 years based in Colorado, and still continue both, but mainly the vet side. And we've been teaching medical acupuncture for veterinarians since 1998. I taught at Colorado State University for 20 years. We began it there and then just grew out of that. And now have my own school in Fort Collins, CuraCore Academy, where we hold our classes. One of the new things we've done beginning over the past year or two has been developing classes building with clay, and a lot of people have familiarity with the Canakin and the Equikin models, so we've used them in some of our classes too. And now I'm beginning an online, so purely online, myofascial relationships of acupuncture points in the dog course, and people can buy the Canakin or they can buy just another type of canine skeletal model. But what I'm finding that really fits in with the Vet Rehab Summit is that when we build these structures with our hands and have to consider layer by layer, okay, what would come first on the skeleton? What attaches to the bone? And then I like to know what's the clinical significance of that. So we talk about that. And then when we have acupuncture courses, we talk about the relationships there. So I love how the vet rehab veterinary field is I mean, you certainly have your still mainstream drugs and surgery
Mm,
people, but there's been such a proliferation of interest and research and education in the soft
mm,
tissues and now in addition the fascia. And so it's just
mm.
wonderful to see and very convenient because it's what I've been teaching, and it's nice to have a community like this to grow in.
Nada, that's so interesting. I've never done the clay sculpting with on the skeletons, but I love drawing and illustrating, and just having that, especially a cross-sectional view, trying to figure out
Oh yeah.
what goes where in which layer, and as you go down the spinal levels, or at different spinal levels, I should say, the different, yeah, the different muscle layers. It's not always obvious from the textbooks how everything is put together. So it's really useful to be able to build something, or create something in an artistic way, right? Because it engages a different part of your brain. It makes you ask questions that aren't obvious when you're just studying from a textbook or with your hands on the patient. So I really love that. How did you start with those clay anatomy models?
Well, I'd known that many courses have used them, at least in the US. And everybody that I had talked to remembers loving building the structures. So it was a real high point in their class. What I also noticed, though, and where I thought, well, maybe I'm going to do it just a bit differently, is that while they remember the experience, when you get into that creative mode, like you with drawing, or just when you're focused on it and you love what you're creating or doing or drawing or whatever it is, you lose track of time a bit. And so just that immersive experience where we can shut our just continual voice track in our head down, shut down, all the social media, and just focus on things, that I think that that's what really grabbed them. And they knew the anatomy at the time, but then we'd have a dog and I'd say, okay, what are you looking at here? And they seem to have forgotten. So I felt like we need to have the next step in building with clay, and that is form and function and clinical relevance. So when I have my dog here, and you mentioned, it's like draw it to know it or build it to know it. So those are really going to help. And then it's like when we had anatomy in first year vet school or med school or physio school or anything, that y- you have to have repetition. And what I see is it's not just, okay, let's learn anatomy again and the insertions and origins and innervations and actions like we did just in notes or whatever. Let's make that active and real. And that is the foundation of medicine. So when we, like, even with the neck, I mean, as we've talked about, uh, and just the different layers there, that where would you start on the model, but also where would you start with your hands. And so it's very important to me that people have as a goal, it's my goal for them to build a 3D anatomy model in their brain. And you do that with your eyes, with your hands, with your knowledge, and your desire to do so. But when I have my hands on a patient, then, and I can just even be like this, and I'm like, okay, for a small carnivore, okay, this is your rhomboideus capitis. So I can feel that. And so with every animal I examine, I'm like, okay, there's your rhomboideus capitis, there's your rhomboideus cervicis, we have splenius and semispinalis, we have brachiocephalicus, we have omotransversarius, because I want to put this anatomy information into use to improve the diagnosis that I have of this animal's pain problem, namely, why are they walking with their head down? This is such a common thing. Instead of okay, I'm going to, I'm a happy dog and I'm going to walk like this, but instead I have my head down. And so that's where I've developed that course, How to See a Dog. And we also think about how to see a cat. But looking at conformation from head to tail and top line to toe, and not only saying, okay, they have a ventral flex neck or they have a kyphotic thoracolumbar region, but then the next step is why? Is it because they can't they can't extend their neck because it hurts, because there's bony changes, because they're pulled down from the front. I mean, we don't know that until we palpate. So the every day, every patient beauty of this is that the anatomy that we built or drew comes alive with our hands and makes a meaningful difference in how we approach our patient, cross fiber palpation, and that befriend them so that they're not scared, so that their muscles are relaxed. Assess them like, okay, I see now. I see a lot of why your head is down, why you can't move, why you can't side bend it, different things. And then whether there's diagnostics or not, it's like we have a much better understanding of who this individual is, what's causing the problem, and how we can help it. So, like doing acupuncture, laser therapy, massage, therapeutic exercise, what are we going to try to do to remedy this? Well, we have to know what it is first. If it's acupuncture and if it's direct, any of the physical medicine modalities, where is the problem? And okay, you could do muscular, soft tissue ultrasound, whatever, radiographs. This stuff is not going to show up in the way you need it to. And then getting back into the summit is that once we also understand the acupuncture channels and or kinetic chains or myofascial lines, however you want to call it, there is quite a bit of overlap. Then we have more information about what is likely to connect with what, because it's not going to be an individual omotransversaris or brachiocephalicus or rhomboideus capitis or any of the other things here and trapezius and all that. There's going to be a group because that's how dysfunction in movement happens, and we can pick that up with our eyes and ears to hear differences in gait, and hands, and put it together in ways that most veterinarians that I know out there that haven't had this type of training, they completely miss. And that's what's so sad is that, okay, costs go up because you keep on missing it. And you're going to radiograph everything and it's not going to show up. The animal continues to suffer and the client continues to, just devote resources that are limited nowadays and waste time when something simple, non-invasive, or minimally invasive, whatever, could be done that the animal is not caused pain by, and get better. So that's where, like, even this whole world that you have with online pet health, that there's so many people that are interested in all this stuff that much of veterinary medicine has just ignored, unfortunately. But the more numbers we have and the more opportunities for learning and growing and doing just a better job, it's like we're getting answers that just aren't being even thought about in the mainstream.
So much of what you've just said is rings true for me and is so important. If I think every single time this comes up for me, it's like a very big aha moment. But movement, something as simple as good functional movement, reduces pain, improves quality of life, can make a huge difference to our patients. And it's the sometimes the last thing on the list of interventions that we're prescribing when it doesn't cost anything. There are massive benefits in terms of owner bond. So simple. Just incorporate some healthy movement. So I really like that because the other thing that you've said that you've really highlighted now and that you focus on a lot with CuraCore is the anatomy and understanding it from different perspectives. It's what I'm loving right now with the myofascial lines because it's a different way of looking at the anatomy and of connecting those dots that helps to cement it in my mind and that has a very direct link to postural changes. So postural changes you can immediately link to this myofascial line and then go in with palpation and have a better idea of your approach and how you're looking at that. So I like that. I like learning things in different ways, right? And with anatomy it's repeat, 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 and the more different viewpoints or perspectives we can come from, the easier it is for us to remember that in the long run. So thank you for sharing that, Nada. So tell us a little bit more about CuraCore and what the different courses are that you offer.
Sure. So CuraCore is so CuraCore Vet is the vet side. CuraCore Med is my human side for continuing education, And as I said, we have an on-site school that I bought the building in 2019, but we also have a lot of online courses and really flourished them with the pandemic and all. So one of m- the most longstanding program, as I had indicated, was the acupuncture. I started that at CSU in 1998 till now, and we've just grown and grown. And everything that we teach is science based. So acupuncture is not about mysteries and metaphors and fires and winds. It's about the nervous system and neuromodulation, neuroanatomy, neurophysiology, and the connective tissue. Because I am an osteopathic physician, so part and parcel of what I've always done since what the 80s when started osteopathic school, medicine is inherently to me palpation and whole person or whole animal, and so I bring that through in my classes, so including medical acupuncture, which after well, during the pandemic we created an opportunity for participants to finish their clinical intensive online. So the acupuncture course is about 85 or 90 hours depending on whether one takes the small animal or the large animal, and we go through the foundational pieces like I've just mentioned, the neurophysiology, modulation, anatomy, all that, and the myofascial connections and pain problems that can be addressed by acupuncture. And then the second section is treatment approaches for either large or small animals. But when you get to the clinical intensive, you can do that from home, wherever in the world you are, or come to our school at in Fort Collins. And for the online piece, we provide an animal model. If you're going fully online, an animal model and push pin, so we can get the acupuncture points identified, and then you work with a live animal and we share with videos, or we do live Zoom sessions, and then I coach people with cases, or my large animal counterparts will coach them with horses, and it's been so effective. We've gotten so many teachers out of what we have called the EMAV course, just the purely online, because you can take your time and really learn. I It's about twice as many hours to do it online as on site, but to me, I think both are important, and just like just to really focus on, to know it, to do a video where we say, okay, here is bladder 10, and it's just caudal to the most cranial border of the atlas, and then here's governor vessel 14 at the cervical. Like, to do that, it's just fun, and you can tell who's really into doing videos and showing, and sometimes they'll dress up their dog. It's like this guy, but not a puppet, and we call him Maverick. And and you can become a kid again. And like you said, you have kids there, but we have so many kids and cats and dogs that bomb the videos, and those are my favorite parts. And I get to know people really well. We've had women veterinarians that have taken the course during their maternity leave, so when they start the course they're pregnant, and by the time they're at their clinical intensive, it's like they have their baby there who's engaging with the dog, and it's just so beautiful. But anyway, and then for several years, we've about 5 years, I forget when our first course was, we've done an integrative rehab and physical medicine program. And that is integrating my osteopathic and veterinary work with my other main teacher is Deanna Rogers, and she's been a physical therapist for humans and dogs for decades. And it's just a lovely way to bring forth a type of rehab that is so patient tailored, so I mean, again, focused on the anatomy and the palpation, but checking to see, are those hamstrings firing, like you had mentioned, about the lines and the anatomy and movement. I mean, movement to give us an opportunity to not do surgery. I mean, I am not a fan of the TPLO, and that I don't make a secret of that. But if we can help the integrity of the stifle joint through neuromotor control, and so often it's the hamstrings that aren't firing. And why is that? And it's like an epidemic in dogs, especially when they have cruciate issues. Is it because they aren't using it? They aren't jumping, they aren't climbing hills and running, and do they just, go outside of their apartment and walk and do their business and go upstairs in the elevator? I mean, I don't know, but you have to again feel for that and identify that. And then think about agonists, antagonists. So it's not just inner pathways, but it's like these are communicating structures, and we have to have balance and correspondence between the muscles. And when there's pathology, myofascial dysfunction, we can get in there and we can resolve that and improve neuromotor control over joint integrity. So there's so much we can do, but the forces that are so pro drug and pro surgery aren't necessarily interested in that. They aren't necessarily going to offer clients that, but it's so powerful. And that's why I love our little pre-chat before we started this, talking about the research that's coming out and justifying these anatomical relationships in the non-human, and the clinical significance of finding them, working with them, palpating them, etc. Anyway, just to wrap things up, yes, we have a photo medicine purely online course. We have a massage course that is both online and on site. And I'm actually starting to teach with the equinology and caninology group. So we're going to have classes with them as well. And I'll do some canikin or clay building classes with them. So I also love how so many different groups we're partnering together, and we're just bigger synergistically with all that. The last one, so we have a botanical medicine course and a cannabis course. And I'm sure there are others, but those are the big five. But rehabilitation from an integrative perspective and medical acupuncture, those are our two biggest courses.
Awesome. I would actually love to I know that's not what we're actually talking about today, but I'd love to dive a little bit more into your perspective on stifle dysfunction,
Mm.
because that's something I'm really looking forward to learning more about at the summit. So I'm going to let you share your perspective on it, and then I want to, while you're talking, just grab my book and
Yeah.
I'll share a few things from there, because I think you guys will be really interested to learn about those myofascial connections around the stifle,
Oh, yeah.
um, and why maybe we need to look at things a little bit differently.
Yes,
Yeah.
please.
Yes,
Okay.
please.
Sure. Yeah, and I just did a Facebook Live yesterday on the anatomy of the pes anserinus, and that's on YouTube. Um, so, so with stifle dysfunction, the first thing that I have a grievance with is how we are cultivated to think about in school. If a dog is lame, hind limb lameness is cruciate until proven otherwise, and then boop, okay, sent to the orthopod, or do it yourself after a 1 or 2 day course. Some of them are online now, and get a TPLO. And I mean, from an osteopathic, like originally perspective, and just a integrative medicine, it's like, why are we cutting bone and then reshaping the conformation of the limb when there's so much else that can be done? That is so highly traumatic. Orthopedic surgery is some of the most painful stuff. And anyway, I won't go on, but it's like the outcomes when I look at animals, you've reshaped their leg, you've plated it in a different direction, and they are not normal. Their movement can never be normal. You've changed the anatomy. Anyway, you can find stuff about that online. So then I think about how can we cultivate health and that neuromotor control over joint integrity. Well, yesterday I was focusing on the pes anserinus and the anatomy, and so I'll do my little thing on that. But before we do, like, palpation of the entire back end and hind limb is imperative to start with, because that first thing, like if there's a hind limb lameness, it's cruciate problems until proven otherwise. No, we should define what it is. It could be trigger point pathology that is causing pain to radiate to the knee, or just causing a lameness in general. There could be a nerve entrapment. There could be, maybe one of the other ligaments or something has been strained, but it doesn't warrant cutting the bone and reshaping the limb. Even if there is some cruciate ligament laxity, let's even go with that. Then what are the muscles that control? What are the muscles that support the craniocruciate in preventing the tibia from translating forward? Well, we've talked about the hamstrings are one of the group. The gastroc contributes some. So think about the hamstrings that are coming from different places, but a lot from the ischial tuberosity, and they're coming and inserting down on the tibia and are going to keep that tibia from translating forward. So those have to fire adequately along with other things in order to assist the little teeny ligament in keeping the joint healthy and stable. But when you get to this pes anserinus, which is, for those of you that do acupuncture, it's spleen 9. It's about spleen 9, just distal to the medial tibial condyle. What that is a pes anserine, or pes anserinus for Latin, means goose foot. And like goose feet, they have the three the toes like that. And so there are 3 tendons that converge in this medial tibial proximal area. And and so so there's the sartorius, which also attaches even up to the thoracolumbar fascia in the dog, but also to the ilium, is coming from the lateral place going anterior or cranial and inserting there. So you're getting information all the way from the spinal region, all the way lateral and anterior. So you need those afferent signals coming from there. So why this is important with the TPLO is will lift that pes anserinus to cut the bone, so it gets disturbed. But the other 2 tendons are the gracilis, coming from the medial aspect, and the semitendinosus, again coming from the ischial tuberosity down. And so you are getting 3 different tendons from different directions around the pelvis that have 3 different nerves. Sartorius is femoral, gracilis is obturator, and semitendinosus is the tibial branch of the sciatic nerve. And so think about the magnitude of information coming into that one area, converging, then getting sent up to the spinal cord and brain, which is responsible for changing the stiffness in the muscle. So like if you're stepping off a sidewalk, you've already prepared. You've seen that you're going to step down. You've stiffened your muscles and you are prepared for where that is. If suddenly there was a hole there that you didn't see, it's like your muscles aren't prepared to gear up to step down. So there's so much that needs to happen to create a healthy joint and maintain proper structure. But when something happens and nerves aren't doing what they need to do, then that's compromised. And is that what happens well before there's any cruciate problem, if there even is a cruciate problem? And so that's why when we have an animal that, even if they're there for just a wellness check, we should be palpating them to find problems early on. And what I've told students in my 20 years at CSU and now beyond, that if you find tenderness at spleen 9, or just I would define it the medial tibial condyle, think about these anatomic relationships and let's see what we can do about that. What is that a signal about that could be, it's a harbinger of maybe things to come? Let's palpate those whole muscles all the way along their length and then treat them with soft tissue techniques, etc. I could go on, but I know we have
etc. I've got to find my unmute button.
Yeah, I know, that's fine.
So just like exactly, I want to highlight exactly the same thing from a different perspective, right? If we look at our fascial lines, there are 11 fascial lines. They've got them so beautifully summarized here in the textbook, if you guys don't have one. And I know this is equine and we're talking about dog stifles right now, but we're also talking about horse stifles, and that's also important, and it's translatable. So there are 11 myofascial lines. How many do you think come together in the stifle or connect in the stifle? Okay, the superficial dorsal line, superficial ventral line, deep ventral line, lateral line, functional line, spiral line. 6 lines are connecting in the stifle. The lateral, functional, and spiral line are all rotational lines that are crossing over the midline and are complicated, essentially, right? The functional line and the spiral line, not the lateral line. What this means to me is that a dysfunction anywhere in the body is going to translate to the stifle, is going to have an effect on the stifle anywhere, from the pole to the back hoof, the contralateral or the ipsilateral front leg. They're both connected to a stifle. It's insane. In the back of this book, there's a section that's called additional tests. where they highlight the stifle and testing the stifle. And I'll read you a paragraph from it. It's titled Fascial Lines and Stifle Symptoms. As the superficial ventral line runs over the dorsal surface of the stifle, the line can be involved in patellar problems expressed as partial or consistent patellar fixation, in which the medial and intermediate patellar ligaments are too tight and the patella is caught on the medial femoral condyle. Conventional treatment involves corrective trimming and or shoeing and or surgery. We are all familiar with, a patella issue in horses and how tricky that can be to treat. But none of these approaches address the primary cause if this arises from other body structures, such as dysfunction of the lumbar vertebra, the sacrum, hock problems, or a too tight superficial ventral line, which extends the hind limb. As the functional line passes on either side of the patella and below it, this line can also have a significant influence on stifle problems, often also involving the lumbar vertebra, thoracolumbar fascia, and or medial interconnection of the gracilis muscle at the ventral crossing over the pubic bone. When treating the dorsal and ventral crossover of the functional line, the myofascia released in these three areas improves stifle and, in particular, patellar function, balance, and stability. With this improvement, hypomobility of the lumbar vertebra could appear, and the need for a manual approach to release these should be evaluated. So there's much more. That was just a piece, but just let's rethink how we're looking at the stifle, because it is a joint that is stabilized by soft tissue, by fascia, by the fascial lines. That is how it's stabilized. So I like that. I like that you highlighted the neurological input, because I also think we don't think about our nervous system as much as we should do, which is, yeah.
Right. Well, and there is an osteopath from Europe. I believe others have said this too, but that the knee, so human, is a neurologic joint, and so we just have different lenses. Because all
Mm,
of the muscles have to have innervation and firing in order to do their thing correctly, and the
mm,
fascia is neurologically talking to, because it's not a ball and socket. It's
mm.
you know it's like this, and so there has to be a tremendous amount of coordination. But I love what you just read, and yeah, I mean, there could be patellar problems, uh, tracking. There can be, like, when we have in the small animals, when we have a patellar luxation. My first thought isn't, well, let's do some surgery and carve things out so that doesn't happen. I want to talk about, okay, is it a medial patellar luxation? You mentioned the gracilis. Like, what is overfiring and maybe pulling? So it's changing the tracking. If it's the gracilis muscle, then I think, when does the gracilis muscle tend to overfire? It tends to overfire as an adductor when there is ligamentous laxity in the hip, because that's going to tend to, like, pull it out. So the dogs will tend to adduct, overfire their gracilis, and then we've got a problem, because the gracilis is going to attach down and impact the patella, as well as other adductors, and just there's so many things that do connect to the patella when you start to look at it. And so then we can track, okay, how did this happen? Because there's also the chronology of it, if you can't, ideally, but there can be other things that precipitated that presenting problem.
Absolutely. And I mean, I must say, like, I don't necessarily hold the opinion that we shouldn't operate on stifles. I don't know. I like to have an evidence-based approach. And right now the evidence supports surgical correction and we have good responses from patients. But I do want to say, let's think about this a little bit differently. Let's put on other lenses. Let's consider other things than just one treatment approach, because it is invasive. I had 3 or 4 weeks ago a veterinarian say to me, do a new stifle procedure, a new, yeah, whatever, stabilizing procedure. And 5 weeks post-op, my patient wasn't weight bearing and they hadn't called me in. They'd been keeping me out because it's fine. He doesn't need to weight bear for 5 weeks. What am I supposed to say to that? How can you not weight bear for 5 weeks and it's okay that he's recovering fine from his surgery?
No, I agree. And while the surgeons have produced a lot of evidence for their
Yeah.
surgeries, there is nothing as of right now that is comparing rehab, acupuncture, the whole integrative thing
Mm.
and movement to those surgeries in the way that it's done now. And I mean, we're seeing more input or evidence about bracing and the value
Mm.
of that. And certain techniques maybe, but let's let's put it to the test
Mm.
and get those animals weight bearing faster and see how
Mm.
non-surgical compares, because we're certainly seeing more evidence of the comparison with intervertebral disc disease, spinal cord
Yes.
injury.
How exciting is that?
Yeah,
Yeah.
which is even like
Mm.
more, it seems like more of a thing when you can't
Mm.
walk and you can get acupuncture and related modalities and rehab and movement, and you can walk again and you didn't need surgery.
Yeah.
Let's so that's what I do, is I do challenge the status quo, because I feel like and I feel like we need to have that voice. We need to get
Mm.
this information about options to clients. And what I would say is, yep, here is the more standard option. If we say standard of care, and it's just because there's so many people doing it, it becomes standard of care. Here's the pros and cons, and then here's this other group of modalities. Here's the pros and cons, and especially with cruciate issues, if that's actually what it is, it's not an emergency. So why not give it time? And because I've known plenty of people that are like, well, I can't get into the orthopedist for my knee replacement or for my cruciate issue, so they sent me to prehab. And then you talk to them 8 weeks later, it's doing fine. I don't need surgery now.
That's yeah, I agree.
So
Okay,
anyway,
so
an outlier, I guess.
let's switch tracks again because that's not like I say, we went on a tangent, but it was a
Yeah,
good tangent. I've
me
actually
too.
been wanting
Yes.
to talk to you about stifles for a while. So yay.
Yay.
Guys, if you have any questions, please ask those questions. We're here to chat with you. And while we have Narda live, let's pick her brain. Let's learn from her. That's the idea and the point. So we mentioned quite a few things now that I want to refer people into the members portal. If you learn more about IVDD and conservative management, we have a webinar by Paul Freeman, which is going to blow your mind. So Paul Freeman is a surgeon, and he's now leaning towards conservative management of his IVDDs because that's what he's finding to be more effective. He asks phenomenally brilliant questions in his webinar. So go watch that. It's in the Online Pet Health Small Animal Membership. Narda, you've spoken about posture and postural changes, and you've presented a webinar for us on that subject. Will you tell us a little bit more about that? And again, you guys can find that webinar in the Small Animal Membership. Again, a phenomenal webinar that you should be watching. Will you tell us a little bit about that webinar and what they can find in it?
Thanks. Yeah. Well, again get back to my how to see a dog or other animal, and to look from nose to tail and top line to toe, and also so we would be in with the face. What is the mentation? What is the awareness? Are there any obvious cranial nerve defects? What kind of emotions are affecting this individual that could show up in
Mm.
just the posture, the soma, and movement? So, are they anxious? Are they relaxed? Are they depressed? What's going on there? But in the same way that we would want to analyze radiographs systematically and not zero in on, okay, I see there's one problem there and I'm going to ignore everything else. That's why the systematic approach to look at the head, you know, step by step, going through the body, is important, so you don't miss the bigger picture. So often in the case reports people submit for acupuncture, they do a good job, but if I do see that and I warn them in advance, if I see that the dog is moving like this, and when they want to turn, that they won't side bend their head, but they turn their whole body because they can't really move their neck from side to side, then I'll say, Did you notice that?" Because they have to submit videos of these patients before and after treatment. So that allows me to see what did they potentially miss, if they missed anything, or good job, because but it's just before they go into the wild. Blue Yonder, I want to know, okay, if there's any tips I can provide. But anyway, the neck is crucial, and its movement, its position, etc. But you know, if let's say an animal was down, so paraplegic or whatever, I mean, if they're like this and they've got a big kyphosis in that thoracolumbar region, and they're probably going to be tender and tense there as well. Yes, it could be a T3 to L3 myelopathy, and we would do the reflexes and try to assess that. But it's like, look, the body is telling you it's here. So let's not, if we're going to even MRI, let's not, that's where it needs to focus. Still do complete things, but let's direct our resources to where the body is saying it is. And maybe there wouldn't be an MRI, but still we could use some acupuncture, laser, maybe gentle massage, but just bring to bear what seems right in that area so that we can help to correct the inflammation, the changes in circulation, the impact, however it happened on the nervous system, and start to be restorative right then, before further apoptosis and nerve damage and nerve dying takes place. Anyway, then we'll do the same thing. Is there lordosis? Is there kyphosis? Wherever it is along the spine, and then what's the movement position and etc. on the tail. After we've done that, then we can look at, okay, are the limbs moving correctly? Are the joints all flexing? Or like the stifle, a lot of times when they have a problem, it's moving just as a unit, and it doesn't, the joints don't flex and extend. So we look at all that, we get our ideas. I also talk about hair coat as well, and how the fascia can batten down the the skin and sub-Q and fur, so that you actually do see changes where there's a lot of fascial adhesion. And so it's very, very good to notice in cats, because you don't have to do, I mean, cats love massage and they enjoy acupuncture if you approach them correctly. But just even by visual inspection of these animals, there's a lot that you can learn, and I've seen it in our horse cases as well. So something to attend to, because it's just an external manifestation of that, those circulatory, neurologic, and just connective tissue changes from the inside, and it expresses outside. Not as visible in the humans because we have hairless skin usually. So there's all that, but then, having even really expanded my anatomical teaching and explorations, different areas of the, like, I can think of three different areas right now where things get snagged. And so, yes, we can think of the whole line, but where are some common areas that cause the problems that we're seeing? One of them that I see with the head down posture is in this suboccipital region, because you have so many muscles coming up and attaching to the occiput all through here. And if you just gently even feel across there, you don't even have to press hard or anything, just gently feel across it, you'll feel these cables attaching to the back of the head. And many of us, if we get migraines, a lot of times it's that back, it's that nasty little rectus capitis posterior minor that interdigitates with the dura right in the back, and that can cause just all these vagal symptoms because it cross-talks with the vagus and the dura and intracranial aspects. But this is a super important area, because also of these myofascial connections and the spinal nerves that are possibly getting hammered in there. The next one is right here at the scapulocervical, kind of all that area. And a big provocateur there are these rhomboids that get really tendinous. And when you have muscles, you always have these muscles that attach from end to end, unless they're just flat ones on the face. You just don't palpate in the middle. You've got to palpate from end to end, because one of the key things is that the tenderness to palpation is going to be where it attaches to bones. And so if you kind of go in there, like, this is a hotbed of a lot of different myofascial pathology. We've got rhomboids, we've got omotransversalis, we've got multifidus, we've got longissimus, just even in there within reach of your finger. So again, this coming alive of anatomy that you can learn by clay building and by drawing, but coming alive, and you can feel it. And it's like, I know what that is in there. I know what the deep muscle is. I know what the superficial was. I can follow them. I can follow their attachments, and I can identify and verify. And that's like, okay, brachiocephalicus, you're starting there and you're coming down here to the cranial humerus. I can see that whole line. Now I understand why your forelimb isn't moving correctly. I mean, it's just so much fun. It was fun already, but with all this more anatomy, it is explosively fun. And then the other big aha, it was from one of my human patients this past year who gets disablingly bad back pain such that he can't even stand. If his trigger goes off in his quadratus lumborum, he's on the floor writhing. And the only thing, he's had like 4 or 5 surgeries. The only thing that has helped him is acupuncture and electroacupuncture added. Um, and I don't even remember learning about this muscle in vet school or beyond. But the quadratus lumborum is deep to that iliocostalis and attaches on the ventral aspect of these last few ribs, and attaches on the ventral aspect of the ilium, and is between the iliocostalis and the psoas major muscle. It's sandwiched in between there, but it's such a cause of severe back pain in all kinds of species. I hear from horse people, like you just palpate there because you got to go a little bit deep, and it's rock hard in some of these really painful horses, and it just goes untreated because people don't know how to assess it. And they're not even aware of it. So that's again where this world of rehabilitation and integrative medicine from science, from an evidence-based standpoint, that is coming together with online pet health and just different extensions from people teaching their courses, that and we hope to do it too with CuraCore, and we hope we're filling that void as well. But just this massive amount of giving attention to concerns and conditions that have flown under the radar for time immemorial till now.
I love that we share that passion.
Yeah,
In the
too.
anatomy, like you say, it was fun before, but when you
Yeah,
really get into the anatomy, oh
right,
my goodness. And
right.
it's especially when you start putting up on different lenses and understanding things different. Like
Mhm.
you were talking now about those kind of sticky spots, and while you were talking, I thought of those are the biggest myodural bridges are sitting there at the atlantoaxial and atlanto-occipital, and they have muscular, there's a myodural bridge muscle to your spinal cord, and the same thing in your cervicothoracic junction. Your nerve roots are coming out there for the brachial plexus. You have myodural bridges there, and repeat for that lumbar, the lumbar sacral area, your myodural bridges, your nerve roots, your plexus. It just, these are things we need to, we're not, when we change the way we look at things, the things we look at change, and
Ooh, I
that's the
love that.
thing. Yeah,
Hmm.
that one is it for me for this year, this summit.
Mm.
That is my quote. And you mentioned like the protraction line, and when we realize that the protraction line of the forelimb is connected to internal rotation of the forelimb, we have another tool to play with, right? If we, protraction and internal rotation, they go hand in hand. How can I use that information to work with this patient in functional movement in ways that can help improve their function? Oh, okay. What would be the one thought that you want to leave our listeners with today?
Well, we've talked about it quite a bit, and I would just consolidate it to the more you know anatomy, the better your clinical outcomes will be. All comes down to that.
Anatomy, anatomy,
Anatomy is
anatomy.
the foundation of medicine.
Awesome. Narda, thank you for your time today. It's been great having you. Have a great day, everyone.
Yeah, same for you. Bye-bye.
Bye.
If you enjoyed this podcast, please hit the subscribe button so you get notified every time I load a new podcast. I'm here every week talking to vet rehab therapists from all over the world about all things vet rehab. Don't forget to bookmark the next Vet Rehab Summit on Saturday, the 31st of August, 2024. Come and be a part of the world's largest online veterinary rehabilitation conference created specifically for you, the vet rehabber community. Onlinepethealth members get VIP complimentary access to the Vet Rehab Summit. For more information about continuing education for vet rehabbers, you can go to onlinepethealth.com.